Good afternoon, everyone, and welcome. My name is Jennifer Kolker. I'm the Associate Dean of Practice at the Dornsife School of Public Health, and I'm thrilled to welcome you all to our webinar this afternoon on COVID and cities. This webinar is part of a series that began last spring and will continue through this fall and until we no longer have anything to talk about. With me today are three of my colleagues: Oxiris Barbot, Senior Fellow for Public Health and Social Justice at the JPB Foundation and former Commissioner of Health for New York City; Usama Bilal, Assistant Professor of Epidemiology and Biostatistics at the Dornsife School of Public Health; and Chrissie Juliano, the Executive Director of the Big Cities Health Coalition. It was just about 6 months ago that Usama and I were here discussing COVID and cities. At that time, cities in Asia and Europe had been hard hit. New York City was deep in their COVID epidemic. And here in Philadelphia, we were just hitting our peak, though we didn't quite know that yet. Coast had been hit hard in the US. Much of the country was still under a stay-at-home order. Cities were and I don't think that many of us predicted that most public schools around the world would remain closed at the start of this academic year. So now we have seen a pandemic flow and ebb and flow in cities. We've seen the variation in policy at the city level and are learning more and more about COVID data as we strive to learn more about the disease and how best to control it. So in the next hour, today we will take a look back at what has happened since March, take stock of where we are right now, and talk about some of the challenges that cities face in the months ahead. I will lead with a range of questions for some or all of our panel members, and please feel free to use the Q&A function. We'll try to get to as many questions as we can. So I want to kick us off starting with data. Where are we? And Usama, I'm going to start with you and throw this out. Can you walk us through the data? What have we seen in cities between last spring and now? And how is the US different from other parts of the world?
Thank you, Jen, and thank you to all of the attendees. It's incredible that was 6 months ago. like it was yesterday.
Or lifetime.
Indeed. So from 6 months ago to now, I think one of the key things we saw is that how that first wave of cities that were first affected started, being able to mitigate the pandemic, but then we saw, of course, an explosion in a number of new cities around the country. So mostly focused around Florida and some parts of the South, including Texas, and the Southwest, including Arizona and some other areas. We saw cities that were badly hit, such as Miami, such as Houston, Phoenix, etc. And we saw the wide recognition of the impact of health inequities in all of these cities, which had happened in the other cities, had happened in New York, it had happened in Philadelphia, Boston, etc., etc. But at the beginning, it wasn't that clear. In the second wave, it became very, very clear. It was very obvious everywhere that this was going to be a pandemic, like every other pandemic, that affects mostly the most vulnerable. I think the other aspect that we saw regarding data is the increased use of data for partisan purposes. We saw how, for example, it was the case in Florida, where someone was fired under some circumstances, emerged with a second dashboard, and all of the mess that came with that. So we saw that data has its uses, and that the collection of good quality data is fundamental to be able to follow a pandemic, and we'll continue to see that.
Thank you. Oxiris, you were on the ground and in a leadership position in New York when this all unfolded. Aside from the what was it like, because I can't even imagine what was it like, but in terms of data, how did you start to use data and use it to make decisions on a daily basis and do what you did? New York went from being the biggest hotspot in the country to even though there's some upticks now, one of the best controlled cities in the country. Oh, we can't hear you.
And thanks to, can you hear me? Yeah. Okay, and thanks to Usama for really setting the stage. And as I was hearing, strikes me that COVID has been an example of how data is power, right? And data is power both for good and for not so good. And the degree to which incomplete data renders all of us powerless. So I think, Jennifer, one of the reasons why I think we had the trajectory that we did is because New York City, since 9/11, since H1N1, has invested in a very robust data infrastructure. And so on a daily basis, in fact, on an hourly basis, we get data feeds from every single emergency department across the city telling us what the chief complaints are for people that are coming in. And so very early on, we were able to track the trends of flu because we were still in the middle of flu season, or rather in the end of flu season, and be able to distinguish the visits that were coming in for influenza-like illness based on their test results, right? So we were able to tease out which visits were due to influenza A or B, and then focus in on those ILI visits, we call them influenza-like ILI visits, that had no indication of an underlying etiology. And so that then, on top of all of the other features that were happening as a result of that pandemic, was an early warning system for us to know that we were moving from sporadic imported cases to community transmission. And that was in the beginning of March. The other thing I'll say about, what I think worked for us and what didn't work for us was that in spite of us having such a robust data system, we in public health know this, the data is only as good as the people and the systems that are reporting it. And so very early on, there was a glaring void in the racial and ethnic indicators. And so we made a huge push with our hospital partners, with our laboratory partners to increase and improve the data quality that we were getting. It was certainly a sort of a side route that we had to take that was unanticipated. But when we saw the way in which early data was playing out in terms of the disparities between Black and Brown New Yorkers, we wanted to sort of test the notion of whether this was a data artifact or whether it was in fact due to the way in which the illness was playing out. And early on, I made a decision to release that data to the public, even though it was only half complete. And that really spurred us and our partners in the city and in the state to then increase the urgency with which we were collecting race and ethnicity data, because, that it helped to inform and I think to really change the trajectory of the response and gave us much more rich information about where the levers were to help stop the spread of COVID. And I'll stop there.
Great, thank you. Chrissie, you work with the 30 largest health departments across the country and cities across the US. Is the data ability capacity that we just heard about in New York, is that standard?
No. Thanks, Jen, for having me here. I have spent a lot of the last 6 years saying there's big city health departments and then there's New York City, right? So, our data systems, even in big cities who are fairly well resourced compared to other local health departments, are not where we would all like them to be. We don't have a 21st century public health data system, and that's not the fault of the field or the leadership. We have really failed to, across the system at all levels of government, resourced infrastructure, right? So everybody in public health knows we don't have enough money, but one of the places that has really failed us is in building those data systems and also in building data systems that can talk to each other. So in New York City, they get feeds from healthcare systems. That doesn't happen everywhere. In some cities, there are workarounds. You know, one of our members has this software set, set of software that they not hand input, but sort of transfer data in from some of the health systems. And it's like a back end way to try and figure out what's going on. Because they don't right now have the capacity to, build the fully integrated system. And I think part of that, one other caveat I'd add is that nobody in public health doesn't want to have data, and nobody in public health or governmental public health doesn't want to release the data and tell the story. But, there needs to be decisions made about, are the data good enough? Do we have enough to tell this story? And how is this going to play out in the public? And, as Usama said, is it going to be used for or against? And how's that going to play out on a day-to-day basis?
Great. So recognizing the difficulties that we've had in collecting data on racial disparities, on ethnic disparities, on people working in different industries, Usama, what can you tell us briefly about the disparities that we've seen in cities across the US and across Europe and South America and Africa as well?
So, I could be answering this for COVID-19, for cardiovascular disease, for infant mortality, whatever we look at, these disparities tend to be quite consistent. What we find in general in the US is that racial ethnic minorities, including Black people, including people of Hispanic origin, including indigenous people, they all have higher infection rates, they all have higher mortality rates, they all have higher hospitalization rates, et cetera, et cetera. This is due to several things, including the fact that racial ethnic minorities tend to work in occupations that are more exposed, so frontline workers, and many other positions that tend to offer them more exposure and less availability of protective equipment too. Other aspect is that they tend to live in overcrowded households, which means that isolation becomes very, very challenging. If you're sharing your household with 5 more families and you have 4 members of your family living in the same room and one of them becomes sick, it's very challenging to do any sort of isolation. There is also then higher vulnerability, higher likelihood of if contracting the disease, you're more likely to suffer the consequences of it because you have a higher incidence, a higher prevalence of other chronic conditions. And the reasons behind that have to do with history of systemic racism in this country, immigration laws that put immigrants at higher risk of chronic diseases, et cetera, et cetera. As I said, this is the same thing as with most other diseases. The situation is similar in Europe, so the US is no outlier in this. In Spain, where I'm from, for example, in the neighborhood of Barcelona, the poorest ones have the highest incidence, the highest mortality, et cetera, et cetera. In the UK, there was this huge study with, I think, 17 million people using electronic health records, power of data, where they found that people living in more deprived areas have higher likelihood of dying if they had the disease, have higher likelihood of contracting the disease, et cetera, et cetera. And even adjusting for that, people of color had higher risk of death. We also see this in Latin America, and I haven't looked at the data for other parts of the world, such as Africa or Asia, but I'm sure that the situation is similar. And in the case of Latin America, there is higher mortality and higher incidence in poorer areas. So this is consistent with all of the other things we see in health. Health inequities are universal, they are very persistent, they are consistent across diseases, and COVID-19, if anything, the only thing it has done is exacerbate those.
Great, thank you. So there's been some discussion lately about testing data. Most of the data that we have so far, and CDC talked about this, have been data that's been submitted by just a few places or a few labs that are doing testing. And now we're seeing this proliferation of rapid tests and this kind of test and that kind of test, and there's talk about home testing. How does that change a health department's ability to respond? Are they going to get that same level of data? Are they going to be able to move quickly? How will it muddy the data picture for localities?
Yeah, that's one of the challenges that I think many cities are struggling with in terms of As we increase the availability of point of care testing, where there isn't a machine involved in terms of running the test, how do we then incorporate those test results into our data streams? While at the health department, we had started work on collaborating with larger ambulatory systems that had more sophisticated EMRs. But my concern with that is, even though, yes, it makes the data fuller, what it then does, it excludes those, as I like to call them, onesies and twosies practices, meaning those small practices that tend to provide care to the most challenged communities, right, where they're with the greatest health inequities, and we're not getting their data, we're not getting that information. Mm-hmm. And so as part of our equity response to the data that we were seeing early in the COVID pandemic, we actually mobilized resources to those practices to help them gain access to technology, to telemedicine, to testing, so that we could address that void, if you will, in the data stream. I don't think we are where we need to be, but that's I think an ongoing issue for how we then, and honestly, if we ever get to a coherent national strategy that brings together PCR testing with rapid point of care testing, I think that will then be the Achilles heel of that ideal state, meaning that we need ways in which to incorporate the point of care testing.
And if I could add there, that again, most of these things are not even new, all of these gaps, right? I remember there was a paper that came out in July, title was Socioeconomic Bias in Influenza Surveillance, where they examined which zip codes were covered by ILINet, which is the key influenza surveillance system nationwide, and they found that the highest poverty zip codes are barely covered by it. So we are missing these things for most diseases, not only COVID.
Right. And I think, just to build on what Usama said, I think that's why it's so critical for us in governmental public health to have an equity lens when we are facing these types of emergencies, whether they are acute emergencies such as COVID, or sort of prolonged emergencies like the opioid overdose epidemic, meaning that you look at where the data voids, not only what the data is telling you, but what it's not telling you that you think should be there. And that's, I think, an important component of fully leveraging the power of data to serve communities, and to serve communities in an equitable manner.
Chrissie, do you want to add anything to the perspective of the other 29 big cities?
I would just say it's an ongoing conversation among the cities about how you shift to being able to have a comprehensive picture of testing that's going on. Do you need it? What do you learn? Are there other surveillance ways that cities could figure out the information, and potentially thinking about a shift? Like, we're not all going to get a vaccine on January 1 and be done, right? We're all going to be living with COVID for some time, but we're not going to be holding daily 3 times a week press conferences that say we have 50 cases today, which is 5% more than last week. At some point we're going to have to shift to this. We are all living with this disease. We are all thinking about, what's going on in the communities, and there'll be a you then use that data internally within the health department, but B, getting back to this idea of a national comprehensive plan, how do you message that? And how do you say to the public at large, we're actually moving into this portion of the outbreak or the response, and here's how it's going to change. And it's okay. It's not that we don't have the data and we don't have the testing capacity. We just don't need to be doing X, Y, or Z right now. You know, this is how we're going to move forward.
That's great. That's actually a perfect segue to my next set of questions, which really has to do with communication, risk communication and data communication. Those of us in public health, we could sit and talk about data and the ins and outs of data and testing all day long, and we find it fascinating. Not so much for the public or policymakers necessarily. So the question is really, how do you communicate risk and crisis during an emergency? And so Oxiris, I want to hear from sort of what that was like, especially in the early days. And then going back to Chrissie, what you just talked about, how do we continue the communication again to the public and to policymakers and to employers around where we are?
So clearly, COVID has been the most extreme opportunity for us to put into practice our risk communication skills. And what I found was most useful in the very beginning, and this ties to data, was to be upfront about what we knew and what we didn't know, and to focus on what the systems were that we had in place that would alert us to when new information became available, whether it be new information about how the virus behaved or new information about where in the city we were detecting the virus. And so, you know, just adhering to the basic tenets of risk communication, which is communicating early, communicating frequently, ensuring consistency, and above all else, being absolutely truthful with what you have and what you don't have. I think it was especially critical during COVID that because of the fact that essentially not only our city, but our country and the world shut down, that everybody was focused on every single detail of what was happening, and were paying, rightfully so, we wanted them to pay really close attention. And so that it was very important to ensure that there was a smooth thread of communication that accounted for changes in the context that weren't seen as inconsistencies, that weren't seen as trying to do a bait and switch or changing. It was seen as, okay, we're learning every day about what's happening. This is new information I need to integrate to be better able to protect myself, my family, my community, my city. I guess the last thing, Jennifer, that I'll say about the risk communication was the degree to which I thought it important to sort of set the stage for what was coming, meaning preparing New Yorkers at the city level for the number of deaths that we were anticipating, because at no other time in our lifetime were we about to experience the type of the number of deaths, as well as the period within which those deaths were occurring, and being able to do it in an empathetic way that was direct and didn't beat around the bush, I think in the end made a big difference for the way in which New Yorkers then adhered to the recommendations we were making about staying home, about using face coverings, etc. Right? They were able to absorb like bad news, right? I put myself when I was a doctor, it's like, you know, Miss So-and-so, I don't mean to scare you, but your son has a very serious illness, and this is what's going to happen, and this is how I need you to prepare yourself so that we can get through this together. And that was the same approach that I took with the city. And so I think for, you know, those students that are listening in, risk communication is a critical aspect of public health training that we can't take for granted, and that we cannot cede to those outside of public health.
Chrissie?
So I think that's a great point to build on. You know, notwithstanding the New York City media market, maybe there was a little bit less noise from the national level, right, within the city. I think the challenge for many localities was, and maybe this was also true in New York, but to a lesser extent, the distraction of what was coming from national leaders, and really, you know, confusing the public. And, you know, I think New York City was lucky to have Oxiris and this trusted messenger who had just gone through also a measles outbreak, right? So the city had sort of been through this relationship a little bit. I think the other thing to think about is that, you know, we have a number of really good communicators across the Big Cities Health Coalition members, and everybody has a different style. So, you know, I think sometimes when we think about crisis communication, we think about this little box, and there are absolutely, you know, important pieces of the message, but everybody does it a little bit differently, and that's okay. You know, and I think as we move, to go back to sort of where you started, Jen, as we move to this different phase, we need to make sure that as many people as possible are speaking with the same voice. You know, it was a critically important message that did not get out from the federal level, frankly, was that we didn't know what we knew. We didn't know what we didn't know, right, in February and March. And we've learned a lot, and that affected how people across the country responded at all levels of government. And that's okay. It's not that anybody was wrong in February, it's that we just didn't know, you know, and as Oxiris said, that's a key part of the message. And also, you know, there were some leaders within the CDC that really wanted to get this message out that said, you know, life as we know it is going to change, which in February sounded really dramatic, but 6 months later feels really realistic, right? So thinking about who the trusted messengers are and what those consistent messages are also is very important. And then, you know, sort of across the field, talking to colleagues, you know, whether it's folks within the big cities share that on phone calls. I know that the state health officials do that, you know, and other locals in different jurisdictions, but really thinking about, okay, so maybe where, you know, within this section of, I'm not going to name a state, but within this state, we're going to decide that we're not going to release, you know, all of our new cases 3 days a week. And let's do that consistently.
Mm-hmm.
You know, it's a really simple example, but to sort of be consistent and manage those expectations among the public of sort of where we're going and what you need to know and what you don't need to know. And, you know, we're going to do the best we can for you. And that's what we continue to do. And I think some of that has gotten lost in all the political drama, is that people who work in governmental public health at every level just want to keep people healthy and safe. Like, it's really that simple. And sometimes that gets lost in, you know, again, sort of the drama day to day.
Usama, looking at a more sort of international perspective, recognize, of course, you're living here and hearing the communication that's going on, but do you think there are big differences in kind of the communication early on and midpoint in places in Europe and Latin America than in the US?
Well, I think like in the US, where there is wide heterogeneity in how different public health officials and government officials have communicated, this is true for Europe, for Latin America, and for the rest of the world. And just as an example, a very recent example, Spain is now in the middle of a second wave, starting again very intensely in Madrid, such as the first wave. And after a few back and forths between the, let's say, the state and the national government, I think I read just now a moment ago that they are going to declare a second state of emergency. While this is happening, the justice system in Spain has declared that the lockdown is not legal and that people must be allowed to move. And at the same time, the regional government is saying, no, please don't move. So there is all of these messages that are contradictory. And next Monday is the National Spain Day, blah, blah, blah. So people tend to move in this weekend. So what is going to happen in this weekend will probably determine a lot of things on how the pandemic will evolve in the next few weeks or the couple next months in Spain. And people are facing that with contradictory messaging from every level of government. Other examples of problematic communications, we saw that for example, in Brazil, with the president of Brazil sending messages that are actually very similar to our own president here, focusing on hydroxychloroquine, focusing on how, this is really not too much of a big deal, no masks, all of these things. And all of these things I think are happening with a series of leaders worldwide that are more focused on their personal self than on the public. And that's the opposite of public health, right? Public health is not focusing about individual people, it's focusing about the entire population. And several leaders across the world, here, Brazil, Mexico, other leaders have also sent completely conflicting messages around. Another example, again, in this case from Mexico, very early in the pandemic, the president was hugging people and he said that was fine because he was fine and he had this little thing in his pocket that will protect him from the virus. So what's the message that is being sent around? It's the same thing as with the lack of masks by our own president here the other day after leaving the hospital, right? It's the same thing. So this confuses people because then should we wear masks, should we not? Then the CDC posts something on their website, then they remove it, which creates a lot more confusion. So I think that consistency that both Oxiris and Chrissie were mentioning is key. But that requires coordination, and coordination requires leadership, and we unfortunately have very little of that.
So how do we go from crisis communication to, which we had to do early on, particularly here, March, April, stay-at-home orders, things like that, moving into, as Chrissie, as you said, we're not all getting a vaccine on January 1st. There's a little, dagger to my heart when I heard you say that. To the sort of ongoing risk communication. How do health departments make that transition, recognizing that we are on the verge of a crisis again at any minute, right? All it takes is a little bit of a surge. So, Oxiris, I'll start with you. How do you make that transition as we have certainly people, even the best intention of people who are getting that, COVID fatigue. They've been listening, they've been hearing the communication, and they are tired of being good.
Yeah, that phrase, tired of being good. So early on, and I think it was probably, end of May, maybe beginning of June, when it looked, all the data that we were looking at we were on the right trajectory. I had my team, and again, this is how the New York City Health Department is different than other health departments, but I think there's an opportunity here for state and cities, et cetera. But the point is, I gave them direction to say, we don't know how long people are going to need to stay at home. We don't have a good sense of how long we're going to need people to wear face coverings. We need to start now developing messages about how we live our lives in spite of COVID. And so, we released, I had an amazing team. The New York City Health Department is known for cutting edge communications. And we released, on a one pager on sex and COVID, right? It's like, you got to live life, and sex is a part of life. And so, this made it all over the world because it takes into consideration the realities of what it means to live life in a way that's fulfilling in spite of horrific circumstances that we're all in. And then we developed a series of one-pagers, the gist of it being doing what we could to have people feel like they had agency over their own health and had the tools they needed to feel like they were making informed decisions about their health, the health of their children, families, etc. And it was really basic, right? We called it the core 4, which was use a face covering, practice social distancing, stay home if you're sick, and work from home as much as possible, right? Like simple stuff. It's not anything complicated. And I think that went a long way into helping New Yorkers feel their way through, what it meant to live through COVID. And I think, as we move to this next phase, I think that those of us in public health who have had experience in risk communication, I think we need to get together and talk about then how do we take that messaging to the next level, right? Because as Usama was sort of illustrating as what's happening in Europe, people to a certain extent are tired of this and they're refusing to go into lockdown, quote unquote lockdown again. And to a certain extent, we knew that this was going to happen. To a certain extent, we think that that's what led to greater mortality during the 1918, second wave, where there was much more fatalities. And I wish I had a good answer about, how we amp that messaging up. But we need to be more creative. We need to not scare the bejesus out of people, right? Because that's not going to do anything. And I don't think taking punitive approaches is going to be the long-term approach. And so I think that partnerships between public health leaders with others and other aspects of communications, I think, is a way for us to move forward as a field.
Great. Chrissie, are you seeing anything from some of the other health departments across the country, and as they face this challenge, and recognizing that the cities in the middle of the country are in a very different place in many respects than the cities on either coast in terms of when they hit their peaks, and we've got blue cities and red states, and it's a really different picture in a lot of different cities across the country.
Yeah, it's very different. And as you said, everybody's at a different point, and has different authorities that they can or cannot use within their jurisdictions, right, around things like face coverings. I think the critical point is getting to a message that says public health isn't keeping the economy open, and now I've messed it up. Public health isn't keeping the economy closed the way we can open the economy, right? So we go to restaurants with a face mask. I sat outside at lunch today with a colleague, across the table, socially distanced, we wore masks in, it's not where everybody would like to be, but it was really nice to do that. So, again, if we can, as Oxiris said, wear the face masks and socially distance and make people understand or explain to them better, it's probably the nicer way to say that, that there are things that, individuals can do to mitigate the individual and the community-wide risk. I think that's another piece that has gotten lost in our American individualistic society, is that, I'm not wearing a mask to protect me. I'm actually wearing a mask to protect the people around me, right? And, that message, I think, failed to get through at the front end of the pandemic. And now people have been spending a lot of time explaining that. And I think we're probably closer to a point where people understand that. I had another point I was going to make that has gone out of my head. Yeah, it's gone. But, you know, really, again, getting to this point where we all understand that this is also a long-term thing and not a short-term thing, and messaging that appropriately. I think that's the point I was going to make. You know, the rhetoric coming out of the federal government is not a long haul, right? It's going to be done tomorrow. And then that just puts so much pressure on state and local officials to say to their communities, well, no, actually, you need to do these things in the short and the long term.
If I could just build on
Sure.
that point that Chrissie made, I think it's important to emphasize the fact that public health isn't trying to limit people's individual liberties. We're actually trying to find ways in which they can continue to exercise those liberties in a safe way.
That's an important message. And I agree. And I think this is, again, I think those of us in public health, we get very caught up sometimes in the data and our knowledge that we're doing the right thing. We don't always communicate well about that very, very point. So we've talked about data, we've talked about communication. I want to talk a little bit about policy, because obviously all this data and communication serves to be able to enact policies, implement policies that help keep people safe, as you were just saying. So, Oxiris, tell us a little bit about, because you were sort of at the beginning around what went into the decision to put down that stay-at-home order in New York, which then, of course, then the rest of the country pretty much followed after that. I guess actually Seattle and some of the West Coast cities were ahead, but what was it like?
Surreal. You know, in making that recommendation and in laying out the case, if you will, I think it was a combination of using the data that we had, but also talking to my colleagues on the West Coast that are part of the Big Cities Health Coalition. And I think that that's an important piece of information that, you know, the public should know about, that we talk to each other and that we share lessons learned, that we share how it is that we got to our victories and how it is that we were defeated, and how other cities who may be thinking about the same thing can go about it in different ways. So I spoke at length with Sarah Cody, who was the first health official, you know, that advocated for stay at home. And so it was a combination of the data, the strategy, if you will, that Sarah was so helpful in informing me on, and then working with various other sectors within the city and state to get it over the finish line. And, you know, at that time, we thought we were going to be in this for a relatively short period of time. But we were clear, which is, I think, important to message to the public, that there was no set deadline, right? That we were going to make decisions based on data. And I think that's another sort of piece of information that we need to sort of tease out a little bit, because it's been my experience that sometimes folks in our own field say, that's too complicated for the public to ingest, right? And that's just a failure of our ability to communicate. And so I think being mindful of that and giving the public more credit that they're able to take in information that we would have, I think, in the past thought was too, quote unquote, complicated, is something that worked in our benefit, meaning that we dove into the data, we took New Yorkers with us, and we didn't, we were very transparent with all of our data. And I think that many jurisdictions, both across the country and across the world, really looked at us in terms of the degree to which we shared our data.
Right. So in many ways, the decisions to shut down I don't want to say it was an easy one, but it was sort of an easy one. Like everybody kind of eventually shut down. The policy decisions around reopening, of course, and reopening certain sectors of the economy have been far more complicated. Some cities opened up at later points than their state. That certainly was the case in Philadelphia, has been in the case in New York. Chrissie, you alluded earlier to, some cities have different powers than other in terms of their relationship with their state. So talk a little bit about sort of what that process has been like from kind of the beginning of the reopenings in some of our Florida cities, which were way early, even going through now. Philadelphia just allowed indoor dining a couple weeks ago, same as New York.
Yeah, so first let me say that on the stay-at-home orders, us in public health looking at the data, sure, it was an easy decision, but I have to defend the 30 leaders across the country in the cities that are part of the Big Cities Health Coalition, that it was not an easy decision and it was not an easy thing to say. And I know you didn't mean it like that, but I have to say that for them. I mean, Sarah Cody said to me, before the press conference where she was about to announce it, she walked in and like for a minute, she realized what she was now going to tell the Bay Area, because it was 5 counties or 6 counties that did it together. And it sort of hit her for a moment. And she knew it was the right decision, but now she was going to tell all these people this. And so, there was some gravity on sort of a personal empathetic level, I think that, we can't dismiss. So I think on the reopenings, it has, as you said, varied a lot around authorities, and has brought up, and Jen and I have talked about this, it's brought up a lot of really interesting conversations about where you want local autonomy and where you actually need a cohesive, consistent message, potentially from, the federal government or a state. Recognizing that sometimes cities do need to move slower or in reopening or close sooner. In Texas, we have 6 big cities in Texas. It has been a struggle for them to be able to, frankly, sufficiently protect their communities, because their 6 cities are so different from the rest of the state, and they have been giving various degrees of authority sort of along the way. It sort of started at, no, you can't do that. And it's moved to, okay, maybe you need to do that. We'll see. And that has played out in different ways in different places. The flip side of that story, and again, I don't think I'm telling tales out of school, is that in California, it's sort of been the opposite. The governor has said, has given them a floor, not a ceiling, right? So he's said, you can do this, or you can be, you can go slower. What I've heard from some of our California members is that's actually put them in a terrible position. Right. So even though they have the ability to keep things closed and they think that needs to happen to protect the communities, they're now the ones saying no, even though the governor has said, hey, maybe you can open up. So, clearly nobody is in a situation of winning here. But really, it gets back to communication and the data and explaining why, even in this little public health lens that we all have, why decisions are made and what the goal of those decisions are. So, one thing that we worked on, Jen, with your team was this model of looking at hospitalizations averted and lives saved based on stay-at-home orders. So, we modeled that the first 45 days, or you modeled and we shared, the first 40, right. The first 45 days of stay-at-home orders potentially saved 230,000 deaths and 2.1 million hospitalizations. Now that's a concrete thing that you can say to your community, this is what you did by staying home. And so, members use that sort of individually in their cities, and we were able, at a national level to say, we represent 1 in 5 Americans with these health departments, and here's what happened. So really, thinking about A, making the right policy decisions, but then B, explaining them in an efficient, cohesive way that the public understands that they have real impact.
Great. We have a question. We mentioned that the reopening after national shutdown, for the record, every data point and evidence of virus transmission clearly showed opening should not have happened anywhere as early as was implemented, primarily because it became a gubernatorial decision rather than a national central point, CDC, not the White House. Please comment. Oxiris, Chrissie?
We'll keep looking at each other. I mean, I think the headline is decisions need to be made on science and data by professionals, career staff, you know, experts, whatever word you want to use. And that's hard sometimes, and politicians don't always listen to them. Is that diplomatic?
Sure. Oh, can't hear you. Oxiris, we can't. Oh, there you are. No, now we got you.
Can you hear?
Yeah.
Oh, okay. You know, this has been one of those ongoing tensions, right, between wanting to make decisions in the pure data bubble versus making the decisions that incorporate more of the politics, if you will. And, you know, I don't know how to get us to the place that I want us all to be that Chrissie just laid out, right? Because we're struggling against human nature. And one of the things that I often talk about, you know, post my government service is that sometimes people make decisions out of fear of what might not happen or what might happen versus focusing on the now and the data. And, you know, what those fears might be can range from, will I get reelected? Will I get this, that, or the other thing funded? There are multiple ways in which, you know, the politics in small p as well as politics big P play into this. And I think that in the end, what is incumbent on all of us is civic engagement and holding our elected leaders accountable for what we've elected them for, right? It goes back, I don't want to be overly simplistic, but it goes back to the power of the vote, right? Mm-hmm. It's when we're thinking about who it is that we're going to vote for, to ask them the hard questions, right? Tell me about the decision of a lifetime that you had to make, and like walk me through that. As a constituent, I want to know, what are you going to do when it's your turn to have your finger on the button?
That's great. Terrific.
That was much more diplomatic.
So I'm going to ask each of you, we're running out of time, so I'm going to ask each of you a set of two questions, but we're going to do one set first and the next. The first I'm going to ask each of you is, what do you see as the greatest challenge facing cities in the coming weeks, months? And then I'll do the second round when we're done. So Sam, I'm going to start with you. What's the greatest challenge in moving forward?
Yes. So now I think how do we address in general, and this again, my constant theme is, this is nothing new. How do we address inequality and COVID? Because I think inequality is at the root of our incapacity to control this pandemic. We cannot control it because people cannot stay home and eat at the same time because they have to go work. We cannot control it because we don't have the social safety nets for people to be able to stay at home. We cannot control it because people cannot get tested or get healthcare, etc., etc. And that is what is, in my view, and what I really want to prove at some point is that it is these levels of inequality that are making it really hard to control here, to control in Latin America, to control in certain European countries, and what actually makes it possible to control in other areas where they have much more well-developed and well-structured social safety net systems. So how do we address this? For climate change, for whatever is the next pandemic, etc., etc. I think that should be at the heart of public health, because we have seen it this time. A disease, a pandemic such as this one, is able to stop the world and disrupt what we are doing globally in a few months. So another one is coming. How it will come. It won't be coronavirus. It will be another one. It will be one influenza, whatever, another one. Or if not, it will be climate change. So how do we address that? And from the point of view of inequality as the root cause of all of it. And this applies not only to income, it applies to race, it applies to all of the other inequality axes. So that I think is the key challenge for cities. There are more, but that's the one I see most clearly.
Thank you. Oxiris?
So I will build on what Usama said, because I think he's absolutely right. I think then the additional thing that cities will need to contend with is one of the side effects, if you will, and I don't even know if that's the right term, that I see in terms of inequality is the degree to which we have become isolated, even before COVID, right? Like the degree to which people of different socioeconomic strata really saw each other as important to one another's survival. I think we've probably as a country been at an all-time low. And so the challenge, I think, for cities and for all of us moving forward is, how do we take the degree that so many people have now come together in ways emotionally that we haven't before? How do we continue building on that so that we see our interdependency as a strength and not a weakness?
Great. Chrissie?
I should have gone first because I'm going to be much more brass tacks. I think we talked about pandemic fatigue, but I think that the fact that we're hitting pandemic fatigue at a time where we have holidays coming up and flu season and things like that is going to be sort of the next real on the ground challenge. And I worry about that second wave for even those of us who are making smart decisions. I mean, I had a conversation with my husband last night about what are we doing for the holidays, and my mom is on the webinar, so now she's going to hear me say this, but should we be inside with our families for the holidays, and what does that look like, and we're safe because we stay home, and so these are really hard individual decisions. And even those, and maybe it's harder for those of us who think about this every day. I do wonder that sometimes, but we're at a point where the everyday decisions people are making are really going to affect the whole community in some ways now, going into the winter where we can't all just sit outside.
So in our last 2 minutes, I want to end on a positive, because if I don't end on a positive, then I won't get up tomorrow morning. So what have we learned? What are some of the lessons learned? And Oxiris, you and I had a conversation a couple of weeks ago, and you talked about some interesting changes in the way public health may be done. So what are some of the, I don't want to say silver linings because that sounds a little too simplistic, but are things that we've learned how to do, whether it's with data collection or the delivery of services or how we communicate, that we will take with us into public health and into cities in the future that will be a positive when we get through this current crisis? And Oxiris, I'll start with you.
Muted. You're muted.
You're muted.
Oh, there you go.
There you go. Nope, still can't hear you. Wait, still can't hear you.
That's weird.
Oh, now you're muted again.
No, it's gone.
Maybe your AirPod. No. Chrissie, why don't we start with you and we'll see if we can get this.
Lessons learned. I mean, I think in some ways, this has given us an opportunity to sort of go back to what those of us in the field have talked about needing and working on for years, but maybe now having a concrete example. So, I think the counter argument to the challenge of disparities is, I like to think that we've actually now have an opportunity to talk about, you know, all of, again, in a very concrete way, all of the disparities that those of us in public health and similar fields have been talking about for years, but have fallen on deaf ears, you know, and thinking about policies that can mitigate some of that, you know, paid sick leave, things like that, you know, that in our, you know, bluer cities, we have those locally and some states have those, but, you know, that's probably something we need to do at the federal level so that we all have the ability to stay home when we're sick or when a family member is sick. And then also, you know, the very, I don't want to say simple, but maybe elementary things about building our data capacity, building our, you know, risk communication across the field. These really, simple is the wrong word, but foundational pieces of what governmental public health does day in and day out in emergency and not, so that we really can, the system can come out on the other side of this better.
Oxiris?
On what Chrissie said, I think the other thing that I would add just briefly is that I will probably no longer accept we can't do that, right? Because we as a country, as a city, have demonstrated that we were able to do what seemed to have been impossible and have done it in record time. And so, you know, the fact that we were able to stand up various systems to support people to stay home safely in isolation and quarantine says a lot about where we need to think about what putting into action our values. And so I, especially in service of equity, the way that Chrissie laid out, so I'm very hopeful that moving forward, we will have a new, renewed sense of urgency in putting into place policy measures to hardwire wellness because our lives depend on it collectively.
Great, thank you. Usama?
That's a hard one, but I'm thinking. I mentioned before that this was probably one of those situations where disruption has happened globally. But I mentioned this a couple of times. But I think the greatest existential threat we have now, of course, is climate change, and I think that what Oxiris just said is very important. We cannot accept anymore. We cannot do that, and that applies to to this investment in fossil fuels, to all of these things that we always say, no, we cannot do that, the economy, blah, blah. Because if we don't do it, we won't be here. And that's the same argument that many people had to say for doing the lockdowns, for doing a stay at home. It's we have to do this, otherwise we are not gonna make it. And I think I know that's an argument of fear and it may not sound like the most positive note, but it shows that if there is a will, we can do the things in order to protect each other. And that's the key thing, that the key thing we need to do is protect each other. The good thing about this being an infectious disease is that it becomes very, very clear that unless everyone is safe, no one will be safe. Although, with that being said, we also need to be aware of that the most vulnerable people are the ones getting hardest hit by this, by climate change, by all of it. But definitely, harnessing all of that political will to make those hard changes is going to be fundamental to finish mitigating this, controlling it when we get to that point, and eventually to addressing the other crises.
Great. Well, thank you to all three of you. This was a fantastic discussion. I'm amazed when I think back at what public health has done and continues to do. And of course, we still have a lot of work ahead of us. But we have a great group of colleagues and a great team, and I think we will muddle through. So thank you all. For those of you joining us, I hope you enjoyed this webinar. We have more to come, so check out our website for upcoming talks just like these. Thanks very much, everyone. Bye-bye.